My name is Nicole Asbury, and I am doing an ethics debate question on does medical power of attorney support patient autonomy? When I chose this topic because when I left the med-surg floor to go into the ICU, I seen a lot of stable patients who came in and then they had a change in health status for the worst. And when we received them to the ICU, when we were at the bedside needing to possibly implement advanced life-saving measures, I realized that that was not the time to have that conversation about what they would want for end of life. So then I decided I was going to start to advocate for patients having advanced directives and medical power of attorney papers, and that they needed to have that conversation with their provider and with their family, and especially the person that they appointed to medical power of attorney. I'm very interested in this because patients, when I was on the med-surg floor, patients would come in for surgical procedures, and mostly they had come in and had to have been medically cleared by their physician and maybe their cardiologist or their nephrologist. So when this happened, they were usually in enough health that they could tolerate the procedure. However, sometimes patients would be admitted to our surgical floor who had had medical admissions, for instance, COPD, or they may come in with pneumonia or things like that, congestive heart failure. And while we were in there, they were in there, we would put them on telemetry and monitor their heart. And sometimes we would find underlying sicknesses that may have contributed to the worsening of the disease that they already had. Sometimes we would have to send them to the ICU. And then when I went into the ICU, I seen these patients who had come in with simple admissions, and then we had found something worse. And again, when I came into the ICU, that was not the time to have that conversation with my patients. And some examples that I have are that once I had a patient who he was in end of life, palliative care. He was ready to be comfortable. And I had that conversation with his daughters. He had 3 daughters who were all appointed medical power of attorney on his advanced directive. And 2 of the 3 were okay. They realized that their dad was uncomfortable and that his time to pass was coming. But the 3rd daughter was not willing to accept that. She did not want him to be sent to hospice. She felt like hospice killed patients. And I had to educate her and explain to her that that's not what hospice did. Hospice made our patients comfortable, so they didn't have to pass in a hospital attached to multiple monitors, and where we as nurses on the floor couldn't provide them the attention and the care that they actually deserved at end of life. And I was able to consult hospice to come in and talk to them, and my patient ended up going to hospice to pass peacefully. Another example I have is we have patients who come into the ER with respiratory failure, and they're unable to even say their own name because they're so short of breath. Or they may be in congestive heart failure and just so overloaded with fluid that they're unable to make those decisions or tell us exactly what their wants are. So the family's at the bedside, and the family is unwilling to give up their loved one, so they go ahead and give us the go-ahead to intubate the patient. Once we receive the patient to the ICU and they're more stable, we look in our system and see that they actually do have an advanced directive, and it indicates in their own writing that they want no intubation or no chest compressions. And then our patient is left on the ventilator because then they're unable to make their own decisions, and the medical power of attorney is not willing to terminally extubate because of their wishes. They want to keep them on the ventilator to see how they're going to do. So the question about this is, what is patient autonomy? Patient autonomy is when your patient has decision-making capacity and they're able to make their own decisions, even if that decision is not what the clinician suggests. If a patient comes in and they need a femoral bypass with a graft placement, and the patient says, no, I'm going to go home and pray about it. I'm going to continue to pray about this, and I believe that I will be healed. It may be frustrating for us as providers, but it is also that patient's right. They have that right to refuse that treatment if they have decision-making capacity. And we have to respect that because that is patient autonomy. What is medical power of attorney? Medical power of attorney is when a patient has appointed a person who they trust and have hopefully had the conversation with that their wishes are, if they would ever go into a state of mind that they're unable to make their own decisions, this person who is appointed as their medical power of attorney steps in and is able to consent to procedures, refuse treatment, or even withdraw treatment if it comes to that. If the medical power of attorney and the attending physician disagree with each other, or they feel like what the patient wants, one feels one way and the other feels another, then it's up to the attending to consult another qualified physician or consult the ethics committee, or to follow their hospital procedure as to what they should do during this time when they're in a disagreement with the patient's family or medical power of attorney. Providers, there's a law in West Virginia that states providers cannot be held responsible or liable for any procedure completed that a patient did not want if it's on their advance directive, if we did not know about the advance directive. It sounds like a silly law, but it's very important as we are in a state where there are high amounts of lawsuits against providers. So clinicians cannot be held responsible for anything they didn't know about on an advance directive or medical power of attorney. When we say that there are pros and cons to having an advance directive and medical power of attorney, there are a few cons that can be interpreted even as pros, that if you don't have this conversation as a patient with your medical power of attorney, then the medical power of attorney can't know what your wants are. So then what they want is what you would want if you don't have this conversation with your medical power of attorney. That's why it's so important not only to appoint a person, but then to tell them your wants as the patient if you're ever unable to make your own decisions. Our book states that if CPR would be medically ineffective, that the patient's consent or autonomy is considered less relevant during this time, which is very scary to a patient, because as patients, we want to think that we are ultimately the decision makers in our care, but our book stated that. The West Virginia Ethics website has general standards for medical power of attorney decisions, such as they must be in accordance with the person's wishes, including religious and moral beliefs, and which reflect the values of the person, again reflecting their moral or religious beliefs. If you get on the state ethics website, it also talks about assessment of the best interest of our patient. An assessment, quote unquote, shall include consideration of the person's medical condition, prognosis, the dignity and uniqueness of every person, the possibility and extent of preserving the patient's life, the possibility of preserving, improving, or restoring the person's functionality, the possibility of relieving the person's suffering, the balance of the burdens to the benefits of the proposed treatment or intervention, and such other concerns and values as a reasonable individual in the person's circumstances would wish to consider. End quote. I think this could be interpreted in many different ways, because if you want something but your medical power of attorney feels like that it's not beneficial to you and you're unable to make your own decisions at that time, then your medical power of attorney can override that because they feel like it would be in your best interest. I feel like that could be a pro for some people who may feel like they're end of life, but they have time left that is of good quality, and they're unable to make their own decisions, but the medical power of attorney says, I seen what they were like before they came into the hospital. Their quality of life was good. They were mostly independent. We're going to move forward with these advanced life-saving measures. And so we do, because that is their discretion of the medical power of attorney. According to a 2017 study, 37% of Americans have advance directives, and almost half of that number did not have a chronic illness, which is saying that more and more healthy people are realizing that they need to write down what they want when they're end of life, so that way, as healthcare providers, we know what they want done. It's difficult to know how many medical power of attorney or advance directive papers are overridden by patient autonomy, because a lot of those times when a patient's autonomy is overridden by clinicians or medical power of attorneys, those cases are settled in arbitration or out of court. Both of those are where they're settled at. When we look at registered nurses or nurses who work in acute care settings, 53% of registered nurses work in the hospital, in acute care facilities. And we're not really in the position to have that conversation with our patients about advanced life-saving measures, except on admission when they're stable. A lot of our nurses who are in the ideal position to have this conversation are in private practice with the physician, where they're going to see the patient and there's no rush. If you go into the doctor and they triage you and take your weight and your blood pressure, that's where the nurse could plant the seed to say, do you have an advance directive? Do you have a medical power of attorney? Do you have someone who's appointed to make your decisions if you're ever sick enough that you can't make your own decisions? And then talk to your provider about how important it is for your all's patients to have advance directives and medical power of attorneys, because this is an issue that should be close to every patient's heart, as we'll all either face death or have to face the death of our loved ones. West Virginia does have an e-registry, though, to where our patients can go on and upload their own medical power of attorney or advance directive papers, and any registered clinician can go in and look at them. All they have to look up is their name and their birthday, and that we could pull up their advance directives that they've uploaded. So if we have a patient where I live in Beckley and we have to transfer them to Morgantown or Huntington, the clinicians there, if we forget to send the medical power of attorney or advance directive papers, the clinicians can get on the e-directive website, pull up what the patient wants, and then they're able to still respect our patient's wishes while they're away from home. And I think that this is why it's so important for us as nurses to advocate for our patients. I appreciate your time today, and thank you for encouraging me to look this subject up that's very dear to my heart. Thank you so much.